It's an honor and privilege to introduce Dr. Cameron Wick, who is an assistant professor of Otolaryngology, head and neck surgery at Washington University in St. Louis. He is here talking to us today on cochlear implantation with vestibular Schwannoma resection. So, Cameron, thank you for joining us, and we look forward to your talk.
Oh, thank you all for having me. As we were talking informally, it is really an honor to speak with you all, and a place synonymous with innovation in our field. I hope that this talk will provide some conversation, and look forward to seeing where we go with this material in the field moving forward. So as stated, my talk will be about the auditory nerve test system for cochlear implantation with vestibular Schwannoma resection. And I'll really kind of put cochlear implants and vestibular schwannomas in greater context. A few disclosures relevant to the talk is we do get support from MED-EL. They donate the test devices and cochlear implants for our clinical trial, and I've had some grant funding for this project from the Triological Society. So what we'll cover this morning are little historical perspectives on vestibular schwannomas, the morbidity and innovations that have come in the management of these tumors. Touch upon factors for quality of life and current hearing rehabilitation options. And then I'll get into the auditory nerve test system and review our clinical trial outcomes. And we can also have a discussion on kind of cochlear implants in the setting of these tumors. So as this group is well aware, vestibular schwannomas, benign tumors, eighth cranial nerve, present with hearing loss, tinnitus, and imbalance. Okay, so a little bit of the nomenclature and history of these tumors I think is relevant before we get into innovations. So it was first described by Sandiford in 1777. Then when we get to resections, the first credited resection was McBurney in 1891. This patient passed away following a suboccipital approach. Sir Charles Ballance, I guess, is given credit for the first successful resection, but if you look at the details of this surgery, there's some discussion on whether or not it's actually a meningioma or even reports of a fibrosarcoma, but that's often the first credited successful resection. Horsley was also kind of given credit for one of the first vestibular schwannoma removals in 1905. But, all these cases describe removal of the tumor by the finger sweep technique from the pons. And so they often resulted in pretty horrific injuries and even death. As reported by Krauss in 1912, 31 resections resulted in 26 patients passing away. So moving along, the first idea that this tumor actually arose from one of the vestibular nerves of cranial nerve 8 came from Henschen, who looked at autopsy data. In 1919, Dandy's credited with developing the pneumocephalogram. Thankfully, this no longer in existence, but looking up the historical facts, I thought it was interesting that it was an unpleasant enough experience. They decided to put it in The Exorcist. So, putting air into the CSF space and looking for filling defects. Harvey Cushing, the father of neurosurgery, many interventions to create safer surgery, one of which was the subtotal resection. And so he's credited with lowering the mortality of the surgery to under 20%. Dandy was kind of critical of the subtotal resection, and he kind of looked back at how those patients did, and over a 5-year period, about 50% of them had major recurrences that ultimately led to death. So Walter Dandy, reported on kind of total resections, and with the safety and innovations in surgical techniques, that mortality rate was able to be lowered to 10%. Still, with the total resection, this was a kind of a go for broke technique and resulted in complete facial paralysis pretty much with every surgery. So William House, obviously the father of neurotology and so many innovations, micro drill, the operating microscope, and probably most importantly, the multidisciplinary team-based approach that remains the gold standard today. We've also been assisted with the management of these tumors through development of Gamma Knife, which was first developed in 1967, first came to the United States at University of Pittsburgh in 1987. And then also the improvement in detecting these tumors with development of the MRI, which was FDA approved in the early 80s. So major advances in surgery, in skull-based surgery, and multidisciplinary care and anesthesia and dissection technique have really kind of changed the landscape of surgical management for these tumors. And so the current surgical morbidity that we often talk about is, thankfully, mortality is extremely rare. Facial weakness, there can be a spectrum here, really correlates with tumor size. And still, when you manipulate tumors around that nerve, we can expect the occasional weakness immediately after surgery. But we now know that, this doesn't need to be a go for broke. There can be near total or subtotal resections, and really keeping the facial nerve intact is paramount in most of these surgeries. Still, there are CSF leaks we need to deal with, and pretty variable responses to headaches and balance and facial numbness that I don't think should be overlooked. So when when patients come in with a new diagnosis, right? This has been the treatment paradigm for a while: observation, surgery, or radiation. And we all talk about, various growth rates and maybe even some of these tumors stopping to grow, or at least having a saltatory pattern of irregular growth. The hearing preservation surgeries, these are the retrosigmoid and middle cranial fossa. These are pretty unique tumors, small at the right location, that we're able to pluck out, and your institution has obviously been huge in describing when that is appropriate, especially from the middle fossa approach. So when patients come in with no useful hearing, then typically we'll lean towards the translabyrinthine surgery or one of the stereotactic radiation options. So when we think about hearing with this current treatment paradigm, boy, there's still that we just really don't understand. This kind of poor correlation with tumor growth, tumor size. We all have patients in our practice with these, medium to large tumors, and their hearing is great. We don't understand why that is. Interesting work on kind of cytokines and tumor secretions, or perhaps secondary hydrops pictures, or maybe some of the modern work that's showing that, these tumors actually have inflammatory microenvironment with macrophages and other things, which may lead to their kind of erratic behavior and hearing response. In general, even though we don't understand a lot about the hearing loss mechanism, we do know that unfortunately these patients have a tumor on their nerves of hearing and balance. And so in general, this leads to loss of serviceable hearing over time, and roughly 80% is a number, kind of a broad number that I'll quote patients. That 80%, so where does that come from? So here's a study out of Norway where they observed patients. They observed them for, on average, 9.5 years. So a good number, about 50%, were coming into this study with non-serviceable hearing. And at the end of that 10-year period, 83% of their observed cohort ended up with non-serviceable hearing, and 62% with a word score less than 50%. This study did find that growing tumors lost hearing, and that patients with really good baselines, even 100% word scores, perhaps were able to save their hearing longer. Collaboration between Mayo Clinic and a group in Bergen, Norway. I'm sorry, that last study was from Denmark. This is the collaboration from Mayo and Norway, and they looked at a large group of patients with different treatment options. So our standard observation, surgery, and radiation, mean average of 7.5 years, and still around 80% ended up with non-serviceable hearing. Interesting, this one kind of patient-reported outcome measure with a hearing handicap inventory for adults just demonstrates that even those with hearing loss really had wide variation in their deficits from that. I'll keep moving for the sake of time. Obviously, we can have questions later. So also as we kind of move towards innovations, yes. Okay. As we move towards innovations in the space, I think it's important to recognize kind of how many of these tumors we're diagnosing and kind of what the current landscape is for the tumors that we are diagnosing. So this is relevant for incidence and prevalence. And just to recap some basic epidemiology, incidence is the number of people in a population that develop new disease over a specific time period, whereas prevalence is proportion of persons in that population who have a particular disease over a specific time point. And, the vestibular schwannoma management is really turned in some degrees into a chronic disease care. And so there are more people in the population kind of walking around with these tumors. And so the historical incidence rate was this 1 per 100,000 person years. This is based on temporal bone studies, brain tumor registries, which are kind of inherently flawed because you have to have a tissue sample typically to register for it. And I think kind of a modern incidence rate is perhaps 3 to 5 per 100,000. And as we get older, some estimates are even as high as 20 per 100,000. And I think this aligns up more of what we see clinically in that, these tumors are out there, they're getting diagnosed. And when you think about a lifetime prevalence, some of these studies are even reporting as high as 1 in 500 persons. Okay. So these tumors are out there and we're finding them earlier. So, before MRIs, it was rare to find a small tumor, whereas currently, that's the standard. They're usually in this small to maybe pushing medium size, but a lot of them are coming in with very small tumors. And this is due to MRIs, obviously, but also recognition from our audiology colleagues about asymmetric sensory neurohearing loss and the need for screening, sudden sensory neurohearing loss and other presenting symptoms. So where do we stand right now? So 90% of patients are coming in with a chief complaint of hearing loss. We know that kind of with the current treatment paradigms, aside from those rare tumors that we're able to tackle with retrosigmoid or middle fossa approach, still a lot of these people develop poor long-term hearing. And it kind of begs the question is, okay, well, what's driving their quality of life? So from some of the studies, we know that, just the tumor diagnosis alone results in increased anxiety. I think that's interesting to look at, treatment morbidity. We certainly perseverate talking to the patients and in our own research about, what is the best treatment option. And there's so much gray in how we manage these tumors, but, are the patients actually noticing a difference? I think a big driver is loss of function. Previously this was facial nerve function and currently it's the hearing function. And then balance and facial function are still major issues for certain patients. Not listed there as headache. When patients have headaches from our interventions or from the tumors, that also can be a game changer. Hearing loss and quality of life is really patient dependent. We know that hearing loss is probably overrepresented in some of our patient support groups like the ANA. Understandably, even with spontaneous tumors, it brings up anxiety about hearing loss in the contralateral ear. And then for our patients with neurofibromatosis, this is a real quality of life and survival kind of game changer when you're able to keep hearing in at least one ear with both ears being jeopardized. And this study just kind of shows the variability in patient-reported outcomes with their hearing loss. So these were almost 300 vestibular schwannoma patients. The blue represents about 50 patients with normal hearing. And you see that their hearing loss burden is obviously low despite having a tumor. And then 250 patients with single-sided deafness, and it's a bell-shaped curve regarding their hearing handicap inventory for adults and how bothered they are by it. So this also belabors the point of kind of talking to the patient and really seeing what is their motivating factor for getting an intervention, or what are their goals for the tumor management. Okay, for those patients currently that lose hearing, we know single-sided deafness has major deficits, poor sound localization, difficulty hearing in background noise. So we lose that bilateral squelch phenomenon and kind of the Doppler effect. And so patients don't do well. And, when these are young patients, they're active, they're socially engaged, this can be a real problem for both work and socializing. The current rehabilitation options of contralateral routing of sound hearing aid or the various osseointegrated implants, these are essentially giving up on the bad ear. It's been documented, certainly from your group as well, low patient satisfaction and frankly, pretty low utilization rates after vestibular schwannoma treatment. And so it kind of leaves us seeing if we can do better. One development in the kind of quality of life landscape for vestibular schwannomas was the Penn Acoustic Neuronal Quality of Life Scale, which was validated in 2010. So this has a 0 to 100 scale with higher equaling better quality of life. And it looks at 7 domains relevant for vestibular schwannomas: anxiety, facial function, general health, balance, hearing, energy, and pain. Okay, so there actually is not a lot out there on utilizing this this scale, and I think it is something that our field can do a better job of to try to capture our interventions. I think we all have had patients where we get the tumor out, face is working well, and there's still something that's driving that patient to not be as happy as we would expect from from that kind of result. So here was a study out of Mayo, 244 patients with a variety of management options. And one take-home point is that the diagnosis alone causes anxiety and has an effect on the quality of life of these patients. From a different study, they did point out a minimal clinically important difference of 12 points. So just keep that in mind when we look at these scales. So the study from Mayo, looking at kind of their baseline scores, just to highlight the total scores, really didn't see any baseline difference between patients that went the 3 different treatment routes. And amazingly, after treatment, these scores are largely unchanged, which is pretty wild given, again, how much we I think as a field, and I'll say personally, kind of struggle to kind of match what is the right treatment option for certain patients. And so the take-home point of that paper was a treatment modality, as we know right now, really has minimal influence on quality of life. So that, I think it kind of begs the question of, well, is there a better, treatment modality that we can do? And so kind of the field of surgery is shifting towards minimally invasive approaches. And so just to touch upon these briefly, this was an endoscopic retrosigmoid study out of Michigan Ear Institute, essentially demonstrating feasibility in hearing preservation cases. And overall had reasonable tumor control and hearing preservation, no quality of life data. I was fortunate at UT Southwestern, where I did my fellowship, to be included in some transpromontorial vestibular schwannoma resections. I thought this was a very interesting use of kind of the endoscope and certainly minimally invasive for these relatively small tumors. However, when we're doing that approach, obviously we're going through the cochlea. And so that always kind of, challenged me to say, are we giving up on this cochlea and on this nerve for some of these small tumors? But certainly we demonstrated feasibility. We had 4 patients, they did well with these smallish tumors. Again, we did not collect any quality of life data and really kind of demonstrated feasibility with those studies. To the credit of some of the Italian groups who have a growing series of their trans-prom approaches, they are starting to capture some quality of life data, comparing it to translab and retro-sig. And the take-home point is that, so far that minimally invasive approach still isn't really pushing the needle when it comes to patient quality of life. But at least they're trying to capture the data. Going back to the Mayo study, kind of looking at baseline hearing and then follow-up hearing on that quality of life scale also doesn't show major differences amongst the different treatment modalities. Okay, so we've got management conundrums with these tumors. We've established that we're diagnosing more vestibular schwannomas. The size at diagnosis is decreasing. Still, we have poor long-term hearing preservation rates as a whole. And despite trying different and minimally invasive treatment modalities, doesn't seem to be, fully impacting the quality of life. So this was kind of the background that led us at WashU to say, current treatment options are really failing to restore function. And we feel like the single-sided deafness rehabilitation really is suboptimal. And so, is there an opportunity for some kind of new treatment paradigm with how we manage them? Okay, so what about cochlear implants with tumor resection? So as we were, kind of thinking about a clinical trial and the auditory nerve test system, we wanted to kind of sample what was the published kind of literature out there on whether or not CIs in these tumors are even feasible. So in 1992, Dr. Cueva is credited with kind of demonstrating that the nerve of hearing can be intact despite losing hearing after a hearing preservation surgery. And he did this with a promontory stimulation in 1992. Okay. The first cochlear implant with a vestibular schwannoma resection is credited to Arriaga, and that was in 1995. And they did it simultaneously with the translabyrinthine surgery. Now, from 1995 to, I'd say, up until about 2017, really just kind of sporadic case reports and very few clinical series in the literature. The UNC group in 2017 published one of the first prospective studies doing a translabyrinthine surgery with simultaneous cochlear implantation. And just of note, there was no auditory nerve monitoring during that surgery. So in the literature, there were kind of two different approaches for who were getting cochlear implants. The first was kind of patients with smaller vestibular schwannomas that already had no hearing, and the patients underwent a translabyrinthine approach with simultaneous CI. The second group of patients were those who kind of had a failed hearing preservation approach, and then likely retested with promontory stimulation in the clinic to show that the nerve was intact and had a delayed cochlear implant. So we performed a systematic review, looked at 29 articles, 93 patients, and looked at those two different kind of patient cohorts. And, some of these were European literature, so we couldn't, just use CNC words. So we really looked at two very basic questions. First and foremost, are people using the device daily? And from both groups, the take-home point was yes, about 80% of the time. The second question we tried to answer was, are patients developing open set speech? And the answer was yes, at least some of the time. So about 50% of the time, open set speech was developed. So take-home points where we didn't see any outcome difference between the two approach, and it demonstrates that there is some feasibility of stimulating an auditory nerve in the setting of a previously removed vestibular schwannoma. From a strategic standpoint, the delayed option presents some challenges. Number one, the utilization of promontory stimulation to confirm that the nerve is intact. And then there's also concerns of, that postoperative labyrinthitis ossificans, which really makes the implantation more difficult. And it needs to be said that there's major bias in the reported literature here. And so, these findings should be taken, I think, with at least some grain of salt. Okay, so if feasibility of CIs with vestibular schwannomas has been demonstrated, then can we improve that? And can we improve it with kind of improving how we're monitoring that auditory nerve? So as we're aware, for hearing preservation surgeries, the mainstay of monitoring the auditory nerve are click-evoked, sound-evoked auditory brainstem responses, where we're largely looking at waves 1, 3, and 5, particularly their kind of overall latencies. Okay, so ABR, traditional ABR is obviously not feasible when the patient has lost hearing or during a translabyrinthine approach where we're violating the inner ear. And so one of our first questions was, how can we drive an ABR electrically with a cochlear implant? So before we had the test system available, there were a few cases of NF2, which obviously are challenging cases where the hearing is so critical for these patients' well-being. So in these cases, we opened up a cochlear implant, placed it prior to surgical resection, and tried to run EABRs in an effort to monitor the nerve. So if you look at the surgeon's booklet with the auditory nerve test system, this is what the EABR tracing looks like. Okay, so this is their schematic, but really they're focusing on wave 5, but they kind of demonstrate a wave 2 and wave 3. In reality, it looks much more jumbled. Okay, so here were tracings from one of those NF2 cases, and actually repeatable EABRs. We were able to identify a wave 5, but it's important to look at, there's a lot of artifact here. So essentially no wave 1, no wave 3 because of the electrical artifact. And then depending on the type of electrode you're using, and certainly NF2 with facial nerve tumors and the complexity of those cases, it also brings up non-auditory stimulation. And so what you have highlighted here is really kind of a muscle tracing from facial twitching during the stimulation. So that can disrupt your waveforms. It's also not necessarily feasible to be opening up an expensive device purely for monitoring purposes. So that's really where this test system came in. So the auditory nerve test system, this is developed by Med-El. It has 3 parts. The first part is an auditory nerve test electrode. Think of this like a little mini kind of flex electrode. So it's 18 millimeters in length. It has 3 contacts. It also has a ground. This is disposable. That test electrode then gets connected to what we call a connector cable, which gets draped off the field and attached to their stimulator box. This is the same stimulator box that they would use for their ABI system. So theoretically, that system is going to decrease the price because you don't have all the internal hardware that is reusable in the stimulator box. So the surgical setup, or kind of the concept of the study is, we obviously have a vestibular schwannoma. We're doing a translabyrinthine approach. We open up the facial recess, and prior to opening up the posterior fossa dura, we're putting in this test electrode with its 3 contacts. Okay, then we open up the dura, begin the dissection, and we're stimulating the nerve, getting some of those EABR tracings while the nerve is dissecting. The clinical trial protocol. So, patients greater than 12, we were pretty vague when it comes to tumor size, meaning small and medium tumors, which I'll touch upon. We did want these patients to already have class C or D hearing, so non-serviceable hearing, no prior tumor treatments, and then maybe easier said than done, realistic expectations. All of these patients kind of would make a decision to go down the translabyrinthine tumor resection pathway, regardless of the clinical trial. And if they so decided to go down that and fit this criteria, then we would bring up the possibility of, hey, we may be able to test your nerve and possibly give an implant. Okay, so with kind of this first, I'll call it almost a feasibility trial. There's a good amount of testing involved. So, I think kind of standard pre-op imaging. We add on a CI eval, and then we do a number of surveys, which I'll touch upon. During the surgery, we're running EABRs, but EABRs are not the decision factor for whether or not we place a cochlear implant. That's really dependent upon the surgical team feeling if the auditory nerve is remaining intact. And that's partially because we just don't know what the EABR is going to reliably give us. And so we felt like the standard for doing the simultaneous surgery is kind of the surgeon's perspective on the health of the nerve. At 6 weeks, we activate the implant. We haven't had any problems with swelling or issues with activation. We get our kind of post-op CT, which is part of the WashU protocol for some electrode reconstructions to figure out where it is in the cochlea. And then 3 months and 12 months, we do kind of major CI testing, sound localization, and surveys. So we really, these patients really fill out a lot of patient-reported outcome measures, including the PEN quality of life, tinnitus, dizziness, SSQ, hearing handicap inventory, and now the new CI QOL. Operating room setup. So from the subdermal electrodes, this is the same as a standard ABR. One thing to note about the operating room, it's really important to try and limit your other interference. So we've actually noticed that certain ORs in our institution have more interference than others. Not exactly sure why. Some of it may be related to things on the floor above us. Some of it may be related to whether or not the intraoperative MRI is up and running. Some simple things like, if there are a lot of people in the room, turning off cell phones, turning off non-critical computers, actually unplugging the surgical bed can all make a difference. The signal is triggered from the stimulator box using a computer that's attached to the stimulator box. This is Med-El's Mastro software. And these are just like kind of stimulating a cochlear implant. It's going to be a biphasic pulse. Typical duration is 60 microseconds. And I bring this up just like ABRs, traditional ABRs. This is not real-time monitoring. We need to do, a couple thousand cycles before we can get a weighted average to truly identify a reliable wave 5. And some of the experimentation has been, okay, what current unit level do we need? What is a baseline? What is kind of a baseline latency that we believe? So let's jump into kind of one of the cases. So this is, what it looks like in the operating field. This is a left ear, so standard translabyrinthine approach, facial recess. Here we have the test electrode that's placed. We kind of drape it anteriorly, and without the bulk of the internal receiver, it's pretty easy to kind of get it out of the working field. Then we place the ground under the temporalis. And before we open up that posterior fossa dura, we stimulate at different current levels and we get some baseline wave 5 recordings. Okay, so this is that same patient, 21-year-old with NF2. In our minds, this is the ideal candidate for this type of approach. You know, he's got a small tumor in the right ear, but still has good hearing, and has a relatively small tumor on the left ear, but has already lost his hearing. So there's a possibility of getting this tumor out and keeping the nerve intact. To go along with the complexity of NF2, this patient didn't have one tumor, they actually had 3. So there was one in the vestibule, and you kind of see almost a cleavage plane between the inferior nerve tumor and superior nerve tumor. That's okay. We peeled those back and actually get a pretty clear look at both the auditory and facial nerves, respectively. And so while we're doing the tumor dissection, we're continuing the EABR process, just like we would for a traditional hearing preservation approach. And we're kind of looking to make sure that that wave 5 is maintained. It's a little different kind of framing because you have some artifact, but once the tumor is out and we determined that the nerve was intact, we placed the cochlear implant and repeated to make sure we had a wave 5, which in this case, we felt we did. Okay, so how did the patient do? So baseline 0%, you know, and just thinking about CNC words, you know, maybe didn't do quite as well as we were expecting, especially in the operating room. So we're talking 28% to, you know, 16%. And the patient from a speech clarity standpoint is kind of struggling with it, which I think the numbers indicate. Patient did get major benefit with sound localization. And to start, you know, kind of reinforcing the complexity of vestibular schwannoma care and the patients that we all treat, you know, this young gentleman who has NF2 has some pretty severe anxiety. He had this in the midst of obviously the pandemic stuff. This disrupted his college experience. He was using the CI in the classroom setting, but you know, there were a lot of things going on in this patient's life. And I think that is partially why we're not maybe seeing the numbers jump up like we would. Essentially no change in his THI, hearing handicap inventory, quality of life overall on the Penn scale actually went down a little bit, and as did his hearing. His right ear remains serviceable, but he's you know, not thrilled with the sound quality despite it being NF2 and despite turning a 0% ear into we'll say a 20% ear. Okay, let's look at another case. This one was kind of interesting for the fact that when we first got our baseline EABRs, there really was no wave 5. So again, was this an equipment issue? Was this a cochlear issue? We weren't really sure. So we kept running our protocol, and actually as we kind of opened the tumor up and continued on with the dissection, actually a wave 5 developed. Okay, so was interesting. This wave 5 was very small throughout the case, but maintained at the end. And this patient, kind of like our subject 2, has, you know, had sound awareness, yes, but from a speech clarity standpoint, really kind of underperformed from at least from our cautious expectations. So CNC words after 12 months at 14%. He has a normal contralateral ear. Did have improvement with sound localization and has found the sound awareness to be helpful and is a daily user despite some of the speech clarity issues. Tinnitus was never a big problem for this gentleman, but essentially has gone away. And overall little bump up in the hearing quality of life, and overall his total quality of life is on the good side. So he's doing reasonably well from a kind of a global perspective. Another subject. So subject 4, here's a little nuance for, sometimes if this test electrode is floppy, you can kind of use a little bone wax up in the zygomatic root to secure it. And I'm also showing this picture, conceptually, we were hoping to actually kind of drop a needle kind of electrode at the root entry zone and get some direct measures of the nerve in much more of a real-time monitoring setup. Unfortunately, the pulsations of the CSF make it hard to get that electrode to stick. And probably more importantly, as I showed with the artifact issues, we just don't get any reliable signal from direct nerve monitoring at this point. Okay, so subject 4, she came in with a little better baseline hearing, but due to that tumor and it growing, wanted, proceeded with the trans lab. She has done better. There was actually one point at 6 months where she was up around 60%. It is interesting that her scores have dropped off, and this is something that she's that we're monitoring, and I'll touch upon later. But she is using it on a daily basis. It is helping her, and she is happy with it. One theme that we are seeing is that really does help with sound localization, and based on overall pretty good, not great, but pretty good speech perception scores, we would expect some of this improvement that we're seeing. So tinnitus dropped way off, hearing handicap dropped way off, overall doing pretty well from the total quality of life, and her hearing score, I think, reflects, her pleasure with at least getting some sound in that ear. Okay, I think one last case example. This is our first subject. So again, another look at, pretty standard, insertion through a facial recess. Okay, tumor was removed, nerve was intact. We have clear wave 5 recordings, including at the very end. This woman, woke up great, did, face was working well, discharged per our care path on post-op day 3. And then lo and behold, on day 11, had a delayed facial paralysis. Okay, so she went all the way to a House Brackman 6, treated with steroids. I forget if there were any antivirals, but had a full recovery. And unfortunately, despite us being really optimistic about the wave 5s, she has not developed any sound awareness. Okay, so again, the complexity of these patients and the challenges of kind of patient-reported outcome measures, we're thinking she's going to be doing much worse with kind of this high expectation after surgery of having some sound awareness, and then the letdown of not having it. But ultimately her tinnitus has remained about the same and is pretty manageable. Little bump up in the hearing handicap inventory. Actually, her global, Schwannoma or pentacoustic quality of life score, increased, and her hearing score actually increased a little bit. Don't know what to account for that. So some of those studies, or some of those results, did show a little bit of decline at 12 months. I think there are two things to acknowledge for that. Number one is, surgeon factors, where we're still at some point having to make a subjective decision of kind of cutting the vestibular nerves and saying, hey, the tumor is is done. Let's keep that cochlear nerve intact. And I think that does bring up a question of, as we really try and push for our patients and get these good surgical outcomes, there's a possibility of leaving some residual tumor. Thankfully, with modern CIs, we can monitor the CPA and the IAC. And here was one where, I don't know what this little growth means. Perhaps it's just post-surgical changes. We do, there was some muscle and stuff that was placed in the IAC, but certainly it needs to be monitored. And, our goal would only be to put in the cochlear implant if there's a, thought to be a gross total surgical resection. But I think it's a point that needs to be, to be brought up. The second one is some of the challenges with testing single-sided deafness, masking techniques for that contralateral ear, and some of those protocols. And so some of that is challenging, and thankfully our audiologists are quite nuanced in single-sided deafness care, but it can be challenging to test these patients. Okay, so some summary slides on where we stand with the clinical trial. So, pretty slow enrollment. There's 8 subjects. We're hoping to get 10. We had one withdrawal from the study due to both other unrelated health issues and frankly non-compliance. 4 have completed 12 months. We have our 5th one, which will be pretty close. Leave it to a clinical trial to find weird stuff in these surgeries. So obviously we got a lot of experienced neuroradiologists, neuro-otologists, neurosurgeons. We're all saying these are schwannomas, and what are the odds that we end up having one meningioma and one hemangioma? The joys of a clinical trial, I guess. We've got a couple of people in the works, and frankly, we're hoping to kind of end the recruitment later on this year. And okay, so how did, kind of big picture, how did these patients do from at least just a hearing perspective? So that subject 1, despite good wave 5, had a delayed paralysis and ended up not having sound. Really, really interesting theories on what could have happened there. Was there a vascular event? Was there some, post-operative injury to the nerve or auditory pathway? Subject 2, this was our NF2 gentleman, so it's certainly having some sound, but isn't particularly pleased with it. Subject 3, had a very weak wave 5 that actually got a little bit better during the tumor dissection, has sound awareness, is using it, but, is not necessarily an all-star performer. Subject 4 is doing really well with good words. We need to monitor why hers dropped off. Was that a weird testing day? Because frankly, she's acting like somebody who's more kind of in that 60% category where she was at 6 months. So we need to follow up on that. Subject 5 withdrew. Subject 6 and 8, those are our hemangiomas and meningiomas, which are kind of the odd birds. And then subject 7 is doing well so far. So take home points. The auditory nerve test system, it can give information on the auditory nerve and its overall health. But there's some pretty big caveats to that. Number one, we still have a lot to learn about the reliability of this system. It's kind of a new product and new electrophys testing paradigm for Med-El as well as our audiology group. And these are tough waveforms to interpret. There's a lot of artifact. You lose wave 1 and 3. So far, direct cochlear nerve monitoring has not been feasible. And, the big thing of being cautious is, we just don't know what the predictive value of the EABR is. I think all of us as surgeons would love that, kind of extra physiologic, certainty of knowing that the nerve is there and healthy enough to carry a signal, but how does that actually translate into patient outcomes is very much to be determined. And so, as a summary on CIs with vestibular schwannomas, I give cautious optimism. We as a group certainly are not, hard selling or overselling this as an approach for patients. I think, those in the NF2 space, if we have those small tumors, really ironing out the logistics of this approach for those patients really could be a game changer. But for the spontaneous tumors, I think we've got a lot to learn, and maybe first and foremost is kind of what's really driving the patient for their overall quality of life in their kind of tumor management care. I also think, we need to keep our eyes open about what is the correct delivery mechanism. Simultaneous translab makes sense to us. We're looking right at it. If we know the nerve is intact, just put the cochlear implant in. You're not dealing with, ossification or those other issues. Michigan Ear and an Italian group have now, provided, as well as a group out of Vienna, have put some studies out there on CIs with vestibular schwannomas. And one of the questions is, does the baseline health of the auditory nerve matter? We're kind of seeing that in our small cohort. And, if that nerve is injured, we've already declared that we don't know why the nerve or cochlea gets injured, but if it's injured, is it just not going to be good at carrying the signal? I think also need to keep our eyes open for alternative approaches, such as after stereotactic radiation. We're actually in the process of looking at those results. And I think Vanderbilt has a small series on their experience. Or what about the patient who's had, you pick a number, 5 years, 10 years with no growth and no treatment, would they be somebody that's eligible? This type of clinical trial is really a team game, to say the least. So certainly want to recognize my neurotology colleagues with Dr. Buckman, Dr. Herzog, and the newer partners, Dr. Shu and Dr. Durakovich. We're very fortunate to have great neurosurgery colleagues at WashU, which make it fun to do these types of cases, and a really strong audiology support, as well as research and clinical support. So very thankful for all the team members involved. And with that, it is a real honor to talk to everyone at the House here clinic, and I've learned so much from your teaching over the years, despite not having trained there. And pretty much all my mentors are coming from your teaching realm, and so it's really fun to talk about innovation in such an innovative program. So I really appreciate the honor.
Hello, my name is Dr. Kevin Peng, neurologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.